How you doing, guys? This is Kento at Kamiyama Physical Therapy at the comfort of my home during the coronavirus pandemic. We did a Sciatica webinar yesterday on Tuesday, 3/17 at 2 p.m. Through Zoom and Facebook Live. This video was for people that are going through some sciatica issues or has family or friends or loved ones that have sciatica issues. So the first 15 minutes of the webinar is for you. So it talks about what is sciatica, how does it happen, common reasonings behind it, what are some mechanisms behind it. So you have a little bit more knowledge and less fear when you are going through these sciatica issues. After that 15 to 20 minutes, we went into some Q&A. We had some very educated individuals coming into the call, personal trainers, massage therapists, physical therapists, athletic trainers came into the call to ask these questions. So if you are interested in even kind of deeper or a little more advanced concepts, please keep watching. But I wanted to make this intro video to know that really it's the 15 minutes that you have to watch. Or if you are going to watch, you can watch that it's going to be more about sciatica. So enjoy, stay safe, stay connected. If you have your family, friends that you haven't talked in a while, just give them a call. Keep connected, because by keeping us connected also help us give the feeling of safe. So stay safe, everyone. I'll talk to you soon. Hi, this is Kento at Kamiyama Physical Therapy. Welcome to our channel.
Live on Facebook. All right, great. So everyone that is joining us right now, make sure you are muting yourself. We will get to a Q&A if you have any questions. To your bottom left. To your bottom, yeah. So if you see yourself, if you kind of browse your mouse, on the bottom left, there's a microphone icon that says mute. So make sure you mute yourself. When we go to the Q&A, I will answer any questions that we can. If you have any questions as we go, click the chat icon at the bottom of the screen, and there's a chat icon. So if anyone can actually put something there right now to double check it works, put that in there. For those that are joining in Facebook Live, the weird part about Facebook Live is there's a 10-second lag, about 5 to 10-second lag. So if if you want to interact, it would be weird. So just send us a comment or an email at Kento@KamiyaMaPT.com or dburbano@KamiyaMaPT.com that we can actually send you the link. So we're going to get started. Paul, I see you. Can you just mute your phone or laptop so I don't get any noise from you guys, audio. So go to your left. All right, well, I'll make you guys figure it out. All right, so welcome, guys. Thank you for coming. Hope everyone is doing well. I'm seeing a lot of people that are familiar faces, so thanks for coming in. This was really more for the personal trainers in Tenafly, New Jersey. But hey, like I'm okay with kind of improvising a little bit. I'm always good at improvising. Not always. I've become better at improvising. But because of my other therapists right here, I'm trying to make things more organized so it is more presentable to the public. So that's what we are doing today. So you are allowed to do Q&A at the end, but thanks for joining us. At this time, I'm sure everyone's kind of like not working. Small businesses are working really, struggling with a lot of stuff. So if you are able to like take out or support your personal trainers, support your other therapists, it's really about supporting each other. Let's kind of get through these times together. And this is really to help each other out. Just get a conversation going to get people together. So I am going to share screen. And I'm going into a slideshow. Great. So can someone give me a thumbs up if you guys see the screen? Great. Thanks, guys. All right. So for those are joining in, we are working on the sciatica stuff today. Whoops. So it's talking about how to work with people with sciatica and still train. So it's for personal trainers. We are making it more layman's terms, but hey, like if you guys learn something from it, that's great. So I'll be presenting along with our acupuncturist here, Danny. We are going to be going back and forth to talk about things. And it might be very basic, but if you guys have any further questions, I'm happy to answer. So how we're going to go through the subject today is First, what is sciatica, which most of you probably know, but this is the point of the webinar, so I'm going to talk about it. So you're going to have to be just listening for a couple minutes. How does sciatica happen? The 5 common reasons why sciatica happens. And when I say 5 common reasons, it's the 5 common reasons I see why sciatica happens. How should you modify the workouts? When should you refer out? And 2 exercises to help with sciatica. So couple news, this is a little old PowerPoint. We have been doing an anatomy study group in Tenafly, New Jersey. Danny has been leading it. But because of the circumstances changing, we're not going to sure we're going to be doing it. We may do a webinar, maybe do a webinar on anatomy, but we'll see. And we're going to be doing a sciatica workshop in about sciatica for the Tenafly community. So let's go into sciatica. I'm sure you guys already know what sciatica is. It usually refers to low back problem that involves the sciatic nerve. So sciatica is a really, really general term. So if you ever heard like shoulder impingement, it's the same. It's kind of the same. It's kind of like a very general term that tells us there's something going on in the nerve called the sciatic nerve. So usually if the sciatic nerve is involved, it could be called sciatica. Depending on the individual, it might be called low back pain. Sometimes it's called sacroiliac joint syndrome. It could be L4 herniation, L5 herniation, L5S1 herniation. It just depends on how the person sees it and how they diagnose it. But if it says sciatica, it really doesn't help you from a diagnosis standpoint. You have to realize why sciatica happens. So how does sciatica happen? So this is a general layman's term. Wait, Danny, when are you coming in?
I'm trying to keep up with the Instagram requests.
We got Instagram
go ahead,
requests.
Go ahead,
All right, we're going to keep going. It might be just me. So sorry, guys, if you wanted the Ecuadorian. But I'm trying to be very political. So I'm just going to go when Danny wants to start in, we will start. So this is a very general term. You know, when we talk about sciatica, when the sciatic nerve itself is involved, I kind of describe it to patients as like a kinked water hose. So if you kind of take a look at the PowerPoint here, when the water hose is kinked, water does not flow through the hose. So in a sense, for us, it could be nerve signals. It could be blood that could be restricted. And because of those things, it may affect how you sense, or you might feel numbness and tingling sensations. You might feel weakness. And because of there's kinks happening, and when you have a kink, it just means there's some form of impingement as a possibility. There's some form in the sciatic nerve pathway, there is some form of kink. So it could be at the L4, L5 region. It could be your butt. It could be your hamstring. It could be anything else. So I'm going to quickly stop the share and go through a little bit of the pelvis here. You guys see the pelvis? So, right, so the sciatic nerve comes from, hold on, the L4, L5 going down, right, going down this way off the piriformis and goes down through the leg. So it just depends on where it's impinging. So let's say a person has a disc herniation and it does push into the nerve around here. It could kink here, which could actually create symptoms down the leg. Other reasonings that could happen is when the space here is restricted, where it kind of compresses like this, where if you guys can see right here, it compresses down here, where it could impinge the nerves. Other reasoning that could happen is when the piriformis muscle right here could be affected. So when the piriformis muscle is working too hard, this gets impinged. So it just depends on where it's kinked. And I hope that makes sense to all of us. So we're going to go back to the PowerPoint. Hold on, guys. There you go. So the next point is where and how can it be impinged? Oops, sorry. So where and how can it be impinged? We just talked about bulging disc, herniated disc. Another thing is called the spinostenosis, is when there is a narrowing in space between the vertebral spaces. So basically it's this spot right here in the side. I don't think that's you guys can see from here. Sorry. We're learning as I go. There you go. So like these spaces right here gets smaller and impinged, and it could get an issue, become an issue. Other than that, sometimes SI joint syndromes where the joints of the sacrum could be affected. Piriformis syndrome is a deep butt muscle, and proximal long head of the biceps tendon is a big one. So when those things, when you have a person that has sciatica, those are some things that you want to take a look at from a symptom or pattern standpoint. And I'm going to go into the Complete Anatomy app in a second, which I am doing. And I'll just show you the path of the nerve, so it's a little bit easy for us to see. Oh, there it is. Holy crap. Excuse me, guys. There you go. All right. So, you guys kind of see it? What is going on here? So I think Complete Anatomy just kind of is going through some changes here. I think they just update this here. Sorry, guys. I think they just updated, so it's a little weird. So we're going to go back into the PowerPoint instead, since it's a little bit different right now compared to like literally an hour ago. So those are the spots that we tend to have a tendency to get kinked. So you got to look at those areas. So let's talk about the mechanisms behind how these could be presented. So when a person has bulging disc or herniated disc, if you are in the McKenzie, like the side of how you treat a low back, this is a thought process maybe that the disc itself might be herniated because of too much rounding in the low back. So by going into extension, that could help. In my experiences, it's not always the case, but that is some like theories out there regarding that. When it comes to spinal stenosis, when the second one, it's likely too much extension in the lumbar spine or also compression in the lumbar spine where it takes away the space between the nerves, between the vertebrae. When it comes to SI joint dysfunctions, meaning a pelvis pain, for me and from an experience standpoint, it's lack of deep core and deep hip external rotator tightness, kind of like the piriformis tightness area. And because of those things, it tends to affect the sciatic nerve. The piriformis syndrome is the deep hip tension pinching on the sciatic nerve. So if we stop here again, it's when the muscle that's right in this area gets too tight or too lengthened. It could be either or, affecting the sciatic nerve that pinches it. So very often the case, if you've ever been to a physical therapist and they stretch your piriformis or like this deep butt stretching, that is because there's a possibility is that sciatic nerve is getting affected in this area. Okay. So going back a little bit more, one last one is long head of the bicep tendon, too long of a hamstring muscle. And I wish I could use Complete Anatomy here, guys, because the hamstring tendon, the biceps tendon on the long head biceps tendon is going to be a restricting point for the sciatic nerve. It was working for us. Let me try it one more time for you guys. Let's see if Complete Anatomy will work. And it's giving me some weird stuff going on here. Let me just start from the bottom. Okay. You guys see Complete Anatomy? All right. Let's see. Let me bring it down to just the pelvis or right lower limb. And then we'll get it into the nervous system or so. Oh yeah, it's not working so well. Never mind. Okay. never mind. So we'll keep going with it. So the key thing for here is if you guys know where the biceps tendon, long hair, the biceps tendon is, if you look at the hamstrings on the most outside, it goes all the way up to the buttock area. And that area, along with the piriformis, can get impinged. So for people that have either too tight of a hamstrings, right, you got to double check if the hamstring's too long and weak, or if it's too tight and short. Depending on those two, you may have a long hair of the bicep tendon issue that leads to a sciatica symptom. Another thing that happens with it is what I often tend to see with the long hair of the bicep tendon is it's too long. And because of the hamstring muscle in that area is too long or weak, it tends to affect the sciatica nerve. Okay, so let's talk about common movement patterns with sciatica. So these are the three main ones. It's way more complex than this, if I am being honest, but these are the common ones that could relieve a lot of people. So what I tend to see is people that it tends to be too much arch in the back, or said differently, there's too much activity in the back. So too much activity in the rector spinae muscles that could lead to sciatic symptom. Because sometimes you'll see people that are super kind of like flat in the low back and still have the same issues. When they arch their back, everything still hurts. Other things, toes turned out or hips turned out. So the deep hip external rotators of the muscles are turning the toes out, which tends to restrict the sciatica nerve or sciatic nerve flow. Number three is overleaning to one side more than the other. So you'll see some form of unilateral kind of lean or unilateral dominance to another person. So if you actually see a person walking, let's say a person has left sciatica symptoms, see if they lean more to the left side too much, or see if they lean more to the right side too much. And the key thing is to just correct that. And sometimes those symptoms decrease very, very quickly. So one of the reasons why I wanted to do this workshop is because of the common fears I see or hear from trainers. When you go to, they may have hesitations to refer their client or themselves going to the client, the doctor to physical therapy, because commonly they might tell your clients or you yourself to stop working out. And this is usually rarely the case. It can be worked around and still progress. The question is how. And the key point is to understand and find a physical therapist that works with you. Of course, if there's red flags along with that, we are going to tell the patient to stop exercising or not, maybe stop working out hard. There's ways around it without a question. But you just have to diagnose it and talk to a person that can actually work around it with you. Another thing is, am I doing something wrong to the client? If the symptoms do continue, I would totally consult with a medical professional that has experience in sciatica. Because at least with that, you have an idea if your workouts are still on the right track versus is it hurting your client. Obviously, do no harm is a big thing for all of us, and myself included. So if we can go through that, that'll be great. So this is Q&A time a little bit. If you do have a question, so we got a good amount of people here right now. We just went through a very simple version of sciatica. I see some like old friends from athletic training, physical therapy, personal training. So this was really meant for the trainers that I currently work with, and hopefully they get to see this as well. But does anyone have any questions? If they do, just kind of unmute themselves and then, kind of ask a question, and we can also have a discussion going. Anyone in the chat? Come on, guys. So you've never experienced someone that has had low back pain, numbness down the leg, and you've never had trouble. You guys are perfectly 100% sure you can fix sciaticas. Is that right? Or what do you guys want to learn?
So I've had somebody.
Who is this?
Brad.
Brad, how you doing? Thanks for courageously saying something.
Yeah. I have a friend of mine who was a pretty high level power lifter. Basically woke up in bed and couldn't move. Still has basically atrophy in the left calf. Can't feel his left pinky toe. Works out. He's working out fine. It was, very much a load management issue, as well as some positional stuff. But, that's pretty much where he's at. He's still training, but he still feels the symptoms from time to time.
So Brad, in this, is there a question within that?
So my question is if he doesn't have any glaring asymmetries or imbalances and things like that, we had him doing some PRI principles. He basically went to a physical therapist that, kind of turns their nose up at PRI, and worked on just load management. He didn't feel like he got very far with it. Is the atrophy and the lack of feeling in his outside foot, is that can he go on with that? You know what I mean? Like, is that, I'm just, it's one of those cases that I just don't know how to progress. And it's not like he could go to some of the local physical therapists around here in Maryland that could solve his problem. You know what I mean?
Right. So make sure, Brad, make sure I understand it correctly what you said. So you have a power lifter currently that it has kind of numbness down the left side of his legs, also some atrophy in his left calf. Is that correct?
Yep. Correct. Yep.
And the thing is, he's still able to do everything he needs to do.
Yes. He basically went to a very simplified regimen with a PT, very load management driven, tempo, sometimes shorter range of motion. But outside of that, he still feels some symptoms, in some of the tightness, the nerve tinglings, the left toe, basically not having feeling, the left pinky toe, the atrophy in the left calf, not feeling very strong in the left calf. So that's where he's at. I'm not really sure how to, take care, basically, is there something we need to be doing, or because he can train fine, he just gets these feelings sometimes. Right.
So then, before we say anything, because I'm not here to diagnose or
absolutely.
So before anything, the question first for me is a symptom constant? Is he always has it, or does it come on more on an intermittent basis, meaning it's more activity based? When he does powerlifting or he walks for a while, it starts to happen. That's a big question to make sure we ask.
It's definitely intermittent. The left toe is something he can't sense in training. And he talks about it a lot for sure. But some of the tightness in that SI area is more driven on it, more intermittent driven.
Right. All right. So that's a huge key point, number one, because if it is constant for me, you probably want to get it further checked out, either through a X-ray or MRI or some other medical professional. If it's constant, if it's intermittent, to me, I still think he needs a little bit further work. If it's intermittent, there is some form of pattern that leads to that.
Okay.
We just haven't, or for whoever has been in the medical team, just hasn't figured out what the pattern is, or he hasn't understood what the pattern is that leads to that.
Okay.
So the fact that he can't feel his left pinky toe also means that there's some form of stimulus that's lacking there.
Okay.
It could be the fact that it's it coming from the fact that there's sciatica issues.
Yep.
The outside left pinky side kind of tells me it's like more like the sural nerve area where it's more dermatomal, like more skin based. But he also has atrophy, so there's double things going on there that needs to be double checked. So the good thing is it's intermittent. The second thing is to figure out the pattern, what it is. You might have to dig deeper than just load management.
Yep.
There's definitely more things that need to be assessed.
Absolutely. Cool. Thank you.
No, of course. I'm getting a couple questions. So how do you work with the breath relationship to sciatica? This is Nicole from New York City. Oh man, Nicole, you just want me to answer whatever you want in this one. So how do you work with breath in relationship to sciatica? It really depends. I'll do my best to answer this. I'm gonna make one case here. So Nicole, are you able to kind of unmute yourself and ask a further question?
Yes. Do you hear me now?
Yeah.
Okay, I'm sorry. Oh, hold on, I'll start the video. Okay, there it goes. Yeah, I mean, you can give me any case. I mean, any information you give is good. So I was just wondering, because I know you're saying like deep core could be one as far as limiting the space around the SI joint, I think you said. And so when you're thinking deep core, I was wondering like what you were doing with the breath and that. But you could say anything, and I'd appreciate your information. So
I appreciate it. So then let's make a kind of like a case,
okay.
virtual case. Let's just make one up in a second right now. So let's assume that one side of the nerve is getting compressed. So I'll use this guy right here, right? And let's say it's tipped to the right side, and you're getting symptoms on the right side. And I'm just making those up because when a person says they have sciatica, it could mean the fact that they don't load very well on that side, that it could mean the fact that they can't unload very well on that side, or they could mean just the fact that they don't know how to flex their spine very well, whatever it means. But I'm gonna make a very specific case, so I am 10% answering your question that maybe whatever there is. So let's assume it's the right side is getting pinched. And if it's getting pinched there, in this current case, it's compressing on that right side. Does that make sense? So the goal is to uncompress or decompress that side. How can we do that from a breath standpoint? So breath in this sense and how I use it is creating different pressure systems, or creating how to manage air pressure, gas pressure. So for example, we're gonna go here. If it's this side they're kind of compressed right now, the easy thing to do in let's say a 101 movement 101 standpoint is to go this side. But if I want to use the breath in order, so by the way, catalyst, this is for you guys. For people that you want to decompress it, we're going to use air. So if I breathe out and get this side compressed, and we're going to crease that t-shirt crease. And when I inhale, I direct my air this way in order to decompress. Right? That is an example of how you can use a breath to decompress the spine. Because you're using, when you get good, let's say oblique activation, intercostal activation, you are able to manage pressure and create pressure from the inside out. Right? If I put pressure from the inside out, it can also create distraction. And if I direct it to a certain direction, I am going to distract one side more than the other. Does that make sense?
Yes, that does. That does. That was a great answer. If that was only 10%, I would hate to see 100%. It was great. Thank you, Kento.
You're welcome. You're welcome. I got from Zach from Underground. Zach, thank you for participating wherever you are. Proactive exercise to help prevent it. Oh God, what a general question, buddy. What a general question. So I'm going to be super general about it just because you gave me a general question. Nothing against you, Zach. If you have further ones, please ask further specifically. More than anything, I'll make it super general. When a nerve gets affected, so in a sense, general movement's the best thing to do. So you got to keep moving. Because if you don't move anything, nerves don't flow, bloods don't flow, that's going to have an issue, okay? When you're thinking, I'll go a little bit deeper if you'd like me to. Proactive exercise to help prevent it from a sensory standpoint. If you notice certain things that you have difficulty doing, a lot of physical therapists, let's say personal trainers, all that might tell you, it's like, oh, I have trouble feeling my left glute. Or I have difficulty engaging my hamstring. or I have difficulty engaging my obliques, right? Things that you might be unaware about might be the reasonings that you are having certain symptoms. I don't know if this helps. Because if I talk about how to prevent sciatica symptoms, there's many different theories out there. If I was a McKenzie therapist, I might just say, keep practicing extension, right? Go into cobras for a while and see how that goes. Or just keep moving, right? Chronic low back pain, there's a lot of research out there saying, just walk and just move in a progressive manner, meaning however you can tolerate and however you can move, that's how you're gonna go. So there's not a perfect answer for that, Zach. I'm really sorry to tell you that, but that's my best current answer. These are great questions, guys. I hope you guys are getting something out of it. Does anyone else have any questions? Oh, Colby, look at him. He's got the freaking beard. Look at that guy. How's it going, buddy? You got to unmute. You got to go to your left bottom icon that says the microphone. If you find that, click it and it should unmute your mic. I think it's your beard's fault. Oh, there you go.
There. Can I ask verbally the question?
Please.
Okay. So something that I've been playing around with recently is kind of piggying off the breath question. In the DNS course I took, I talked a lot about IFP and basically getting the abdominal cavity to expand in 360 degrees. I think when I first took it, I took it almost like the traditional belly breathing message, and I kind of wrote it off. And then I've been playing around with it recently and trying to understand what they were talking about. And so basically my question is, what are your thoughts on the abdominal cavity or the abdomen expanding when you inhale, as long as it occurs with a subsequent rib cage expansion?
Got it. So, before I go anywhere, I only took DNS-A, if I'm being honest. So there's not a whole lot of expert opinion on it when it comes to DNS for me.
Right.
But when it comes to the breath, right? When we're trying to get an expansion, any 360 expansion, it's going to be more about the pressure that I'm caring about. And how can I increase my intra-abdominal pressure? So if we're talking about physics, right? So let's say there's this box, right? Let's say it's by 10 by 10 by 10, right? So the volume is set, right? So for that pressure to increase, something from the outside has to get some form of molecules in there to increase in pressure. That must happen. That must happen. So the whole point we talk about, I think what I hear all the time is it's about increasing intra-abdominal pressure in order to create more lumbar stability. In order to do that, the oblique muscles have to be active. So 360 breathing, I absolutely love it. I actually don't mind it at all. The thing that I actually will definitely care about is there opposition created in order to increase intra-abdominal pressure? So if the individual is expanding, but there's nothing in the obliques, there's nothing, that is to me, not in a trunk or thorax or whatever that has intra-abdominal pressure increasing. If anything, the pressure just maintained the same because the volume continued to increase in response to the pressure that came in or the molecules coming in.
Now, do you assess when you watch somebody breathe, looking at it through that lens, if there's a distributed pressure? I think sometimes I'll have clients where they'll maybe bear down with a certain band of internal oblique fibers, and it will, part of the abdominal cavity will be very locked, and then just below or above that, it will be loose. So trying to teach them how to get it to be more of a distributed pressure. Do you have any experience with that?
Yeah. So that's when, when I'm assuming, and let me make sure I understand this correctly, when the individual exhale fully and they get that tension on the oblique areas, So they're nice and tense. But when they inhale, that spot doesn't move, but everything else expands. So it's kind of like, it kind of goes like this.
Yes, yeah.
Right? Even though they're trying to keep it tight, right? So that, to me, at that point, they're actually not getting oblique, those sarcomere contraction when they inhale. They actually lost it. They're just sucking it in.
Okay.
Right? So a cue that helped me before, that has helped, is as you are exhaling and feeling those obliques contracted, I actually tell them to inhale in the obliques while keeping it tight as possible.
Right. Okay.
So not only does their sensory feedback in the obliques, but it will also kind of stay there and expand very slowly in that area.
Okay.
But the oblique itself doesn't really expand too much. It will.
Right.
It will look like it does because like the intercostals and the fascia expands it more, right? But the oblique is still very, very on. So then by doing that, intra-abdominal pressure is increased. There's pressure from the inside out. And to me, that's when it's really, really good.
Gotcha. Okay. Thank you.
Of course. Anyone else? These are great questions. I mean, this is becoming more of the people that are kind of like the curious ones are coming here. Just to let you know, guys, this is more for patients and personal trainers. But hey, I'll still post it. Hopefully someone gets something out of it. Danny, do you have anything you want to add?
I'm trying to keep up with this messages.
Messages? The 30, 40. Anyone else? Tenshi, do you have any questions? Or Brad, Melissa. Melissa, is Paul still there or is he hiding?
I have a question.
Who's it? Is that Paul or Tenshi?
Tenshi.
All right, go for it.
Tenshi. So from like studying PRI, and then we've probably talked about it before, but when you were talking about exhaling with the obliques and then breathing into the obliques so you maintain tension there, when you're breathing with IAP, to me, when I try to do that, it feels like I'm tension breathing, like creating tension, maintaining tension. Is that like how it should be all the time, or is that task dependent, or like, because people ask me sometimes like, am I supposed to breathe like this all the time, or is this when we're just doing the exercises, or is this supposed to like change? So if you could provide some clarification on that.
Yeah. So I'm going to repeat the question to make sure I understand it, so I don't answer the question poorly, or at least I'm at least answering the question that you're asking. So you're saying when you do it right now and we keep in the obliques and you inhale, it feels very tension-based breathing. Now the question beyond that is, am I supposed to breathe like that all the time, or is it more of a certain? Do I breathe like that in a certain context? Is that correct?
Yes.
Okay, so you're right. When you breathe all the way out, if you haven't done that kind of breathing, it feels really, really weird. And also, the common thing I get from patients is like it almost feels suffocating. Mm-hmm. And it's usually because you're breathing into areas that you're not used to breathing in. So the brain feels like, oh wow, this is such a different thing. And the brain loves comfort, meaning predictable patterns that you already have. So even though something is good for you, for them, it feels like it's the wrong thing. It's a negative feedback sometimes because you're not used to it. So yeah, sometimes in the beginning, it feels like a negative or tension-based breathing. And it is, in a sense, but I'm not over-tensing, if that makes any sense. So the key for me when I talk to my patients about it is, can you feel different when you walk? Can you feel different with these things? Like, usually a different positive outcome helps them understand that this is good for them, right? So one thing is I can't guarantee how you breathe is correct because I'm not really assessing you right now, Tenshi. So I can't say this is correct or wrong, how you are describing it. Mm-hmm. But yeah, you're going to feel like that sometimes if you're not used to it. Another thing is, no, you're not going to tell your patients to do this all the time. Absolutely not, right? This is a drill that I give to patients so they can learn how to feel how breathing into spots they usually don't breathe in is possible by doing this way. As they get better at it, what's going to happen is their ability to get into those positions, you don't need as much brain space or brain energy to do so. So as you practice more and more, hopefully what it becomes is more natural for them to breathe the way we like them to breathe. But you are not going to come to do it every single day. They're going to go crazy.
So eventually it'll start to feel more natural. And
I hope so. You know, when you practice enough, and also, they also have to know and trust you as well. I think that's a big thing, because if I don't trust the person that is teaching me this, and there's kind of, in a sense, you're kind of, you know, taking a leap of faith almost. They might continue to have this cycle in their brain say, hey, this doesn't make sense, this doesn't make sense, this doesn't make sense. And that they will never make it that natural. So there's a lot of components to it. So yes, my goal is hopefully they trust me enough, trust the practitioner enough, that this becomes more natural. But it's really just this small progression between, you know, the therapist and the client, or the personal trainer and the client, or whoever, that continues to grow in that direction.
Thank you.
Of course. Of course. Anyone else? My goal was 45 minutes. We're hitting about 40 minutes. Is there anyone else that want to ask questions? Melissa, we are still here. We don't have questions for now. Are you sure? Rue, she's going to send me a text later, probably, and ask questions. Dino, you have any questions? And I got James. Who's this? James and John 2019. You guys got any questions? James, is that, I don't know which James this is, but James, if you have any questions.
James, I'm good.
Oh, there he is. John 2019. If not, just kind of chat. Oh.
Nope, I'm good.
All right, awesome. Awesome.
Kento, I'll ask one more.
Who is it? Oh, Colby, go ahead.
I'll take advantage of this. So can you talk on, if we're kind of categorizing a squat pattern versus a hinge pattern, what you're...
Colby, hold on. This has to be a little bit of sciatica, though. Is it going to relate to sciatica?
I believe so, yes.
You would. Go ahead, go ahead.
Okay. I would assume that somebody with a sciatica issue would have a restriction in sacrum and iliac movement in relation to each other.
Sure.
So whether it be a hinge, a squat, or whatever movement you want to choose, what are you looking for between those two bones in terms of movement that should occur? How are you measuring that? When they're doing something dynamically where you may not be palpating, are you using a kind of objective of questions of what do they feel to test that?
All right, so you're saying what, you know, there's the movement between sacrum and the ilium, and what to make sure those movements are, let's say, optimal.
Or normal, yeah.
Normal, right? And if I choose a squat or if I choose a deadlift, what am I looking at, and how am I objectively seeing that to see if that's happening or not? Is that correct?
Yeah. Yep.
So then it's an easy answer for me. I don't check it like that.
Okay.
Yeah, so that's the simplest answer I can give you. I don't check it that way. I don't know if I can check it so well that way. It's more of a guess game, I think, when it happens that way. When you're looking for like a sacrum nutated or counter nutated with the ilium, because it's such a small motion.
Right.
So what I do take a look at is subjective, meaning what does the patient or client that's in front of you feeling? Because what I care about most of that point, most is probably a bad word to say it, but I care about the individual safety, the feeling of safe and feeling of strong, feeling of I feel I'm supporting myself.
Got it.
So of course they understand the nutation and the the counter nutation and how the idiom goes IR, ER is important to understand from a movement and more deeper concept perspective. But when I'm going through those squats or deadlifts, I am not looking at that.
Got it.
I got a question from Katie Mack. Guys, thank you for coming, man. You guys are just taking the advantage as much as possible. Katie Mack, how to go about unloading a side that seems locked into its pattern. Is she on this call? Facebook? Katie, can you get on to talk to me about this? Can you give her the link? Mm-hmm. How to go about unloading a side that seems locked into its pattern. I cannot answer that for her unless she has a more specific question. So until she has a specific question that comes onto Zoom, anything else? Oh, Tenshi raised his hand. Go, Tenshi. Oh,
I used the button.
Sorry, guys. Because I'm Japanese, I'm allowed to do this. That was very, very Japanese of him. It's on live. Okay, go for it.
Like you mentioned earlier, like Mackenzie is a typical approach for sciatica. Another one that I often see is like neural flossing or neural gliding.
Yeah.
Are there specific moments where you might incorporate that or specific instances where you find that useful?
Yeah.
As opposed to like correcting the movement and just working on the movement itself, but maybe supplemental to that, like are there instances where you would implement it?
For sure. So Tenshi, it's a great question. So, before I keep moving forward with it, I'll just say, that I'm not an expert in nerve flossing, but I understand that how it could be important. So this is going to be more hypothetical for me. Because I've used it in the past before. So it will be supplementary, but the way I may use it is, let's say it's an ulnar nerve pathway issue, right? And you go through an ulnar nerve testing. And what I may ask, or what I may see is what parts of the joints are they actually having trouble to get into those movements, right? So maybe it could be the elbow, maybe it could be the shoulder joint, maybe it could be the collarbone. And depending on what they do with that, I can assess better with that. And then I will utilize that information to improve those joint movements. So let's say, for example, let's say a brachial plexopathy issue, right? And let's say it's more median nerve down this way. And you find out through movement, they can't separate the upper rib cage and the collarbone to separate it. They can do this, they can do the shoulder, they can do this, but they cannot separate here. If that is the case, I am going to work on a drill to help separate these moments.
So you would use it as a more of a diagnostic to zoom into a specific area.
Yeah, or if the patient or client says, this feels good. Because that, to me, they like it. Unless I think it's completely contradictory, right? I will be okay for them to do so. But what I do know, at least in my eyes, in my brain, that there is something that might be having holding them from progressing a little further.
So you might use it to find the kink in the hose that you were like.
That's right.
Okay.
That's right.
Okay.
Yeah, it's a great question.
Thank you.
It's a great question.
Thank you.
You're welcome. Did Katie Mac come around yet?
She has having trouble logging into her phone.
Oh, it's her phone?
Yeah.
All right, Katie, I don't know how to answer that question because it's not specific enough. So sorry. One last question, guys. One more, and then we will finish off. Hopefully you guys liked it. And we may do another one. What the hell? I mean, might as well be supportive to each other during these times. Any other question, anyone? Did Tenshi raise his hand again? Tenshi, did you raise your hand again? Go for it. You're muted.
you mentioned 2 exercises that to address sciatica. Or were you going to go over those?
I was.
Oh, okay.
I was. I don't
Alright.
know if we are. There's a lot of things that kind of went haywire for us.
Okay.
So, you know, we're Danny and I were kind of like working full time right now. Danny's literally answering all the questions on Facebook as we go through this. So we will maybe another time. Maybe another time. I think a lot of the Q&A got answered. The 2 things that I was going to give basically was basically what Nicole talked about, what Nicole and I talked about, how to get one oblique activated to expand this side. And we just used it as a case study right now to help that out. The other one really was a piriformis type of stretch, but done with a good pelvis and ribcage positioning. So if I want to teach it well, that'll take a little bit too long, and I have to go into a next call eventually very soon, so I can't answer it right now. So sorry about that, Tenshi.
Okay.
I love how you're trying to squeeze as much as out of it right now. I love it. I love it. That's
This
all right.
is rare.
Yeah, well, it's rare times right now. All right. So, dude, thanks for coming, guys. I really appreciate it. I really appreciate it. Hope this was good. If you guys liked it, you know, kind of DM me or text me or email me if you guys liked it. And then we might do it again, depending, because who knows how long this is going to be. To me, I want to just be supportive to each other right now. Hopefully, you know, if you guys are a personal trainer or a small business, you know, stay with it, guys. Like, I think this is going to be something that we are forced to do something new and forced to come together and have different ideas to get better. So, you know, this is what I'm trying to do right now, you know, to talk to other people how we're doing, because the better we kind of know together, I think less fear, feel a little more safe, so we can be like, hey, this is going to be okay. So someone gave me a thumbs up. Thanks. Thank you. All right. So yeah, if you guys can give me any feedback, I'll love it. And have a great time, guys. Have a great week.